I'll be here.
Thank you. I'm very excited to have this special presentation today. We want to discuss and present the work that the surgery initiative in global health has been doing in the last several years. It is my special honor to introduce Dr. Coates, who's going to moderate this session. Dr. Coates is the director of the UCLA Center for World Health, and he's also the co-director of the University of California Global Health Institute and the Michael and Sue Steinberg Endowed Professor of Global AIDS Research within the Division of Infectious Diseases at UCLA. Dr. Coates was cited in Science in 2002 as the fourth highest funded scientist in the clinical, social, and behavioral sciences. He was elected to the Institute of Medicine in 2000, and he serves on its board on global health. It is my privilege to introduce Dr. Coates, who's going to moderate the discussion and also introduce the speakers. Thank you so much.
Thank you. Good morning, everybody. Good morning. And welcome. It's I love it. I love a good morning. I love a responsive audience. Thank you for joining us this morning in this particular time of what seems like difficult trouble in the world. It's really encouraging to gather together to talk about a lot of good that a lot of our people are doing in the world. And so we welcome you to this session on global surgery. And what this does is gather together the efforts of many of our faculty who have worked on these things for many, many years. And when you begin to pull them together, you see all of the enormous good that all of the faculty has been doing on their own dime, on their own time in many cases, raising money to make the work happen. And our goal now is to try to bring this together under an umbrella so that we might be able to help with that effort. We might be able to help with fundraising. We might be able to help energize the initiative. We might be able to help make this a signature program of UCLA and raise it to even new heights. So the Global Surgery Initiative, our goal is to improve the surgical health of people in the world with our partners through education, research, and service, and certainly to guide the next generation of surgical leaders to use their vision, talent, and commitment to transform the practice of world health and make a sustainable difference. And our goal is always, as we believe that the sustainability issue is one of investing in the people who are living in the countries that are theirs and of which they're proud, to help them do a better job of even what they do. And that seems to be the theme that pervades all of the efforts that we're going to talk about this morning. The efforts that we're going to talk about this morning really reflect the efforts of the Department of Surgery. And since this is Surgery Grand Rounds, we thought we would focus on those efforts. We're also aware that there are many other efforts of a similar nature in other departments, in emergency medicine, in anesthesiology, in obstetrics and gynecology, in ophthalmology, and orthopedic surgery, and neurosurgery. And we want to organize another session to highlight all of those efforts as well. And when you put them all together, it's really an amazing group of activities of which we can be very proud. I'd like to especially thank Dr. Busatil for his support of this effort in the Department of Surgery. And of course, Dr. Busatil also engages in global surgery through collaborations with our partners at Zhejiang University at the First Affiliated Hospital in the area of liver surgery. and liver transplant and liver cancers. So we're very proud that our chairman has supported this effort, and we thank you very much for your strong support. A little too far. So these are the initiatives of the Global Surgery Initiative. And the role of the Grand Rounds is to describe the role of surgery, to promote partnerships and educational exchanges, to provide examples, to illustrate the role of technology in global education and outreach, and describe the interface between surgical interventions and local culture and context. These are the speakers, and I will introduce them briefly. They will each speak for 10 minutes so that we can have time at the end for panel discussion. So Dr. Chi Chung is a graduate of our general surgery program. He's on summer break from the work he is doing in Ethiopia, where he serves as assistant program director of the Pan-African Academy of Christian Surgeons. He will describe his experiences on the ground as a missionary surgeon. Dr. Shant Shekmedian is a pediatric surgeon. He completed the UCLA Executive Master of Public Health with a certificate in global health. During his lab years, he's involved in evaluating the role and implementing quality improvement and surgical safety in Armenia, and he will provide a background on the role of surgery in global health. Yande Ugarte, who is leading up this effort, is a pediatric surgeon who co-directs our global health education program for medical students. He will discuss partnership development using Mozambique as an example, and in the work in Mozambique, he works very closely with Dean Miller. We're glad to give you that title. Dr. David Chen is a general surgeon at UCLA Santa Monica and clinical director of the Lichtenstein Ahmed Hernia Clinic at UCLA. He will describe his experiences using educational tools and technology to train local surgeons. Dr. Catherine Gilliard is a former Peace Corps volunteer and graduate of the general surgery program. She completed trauma fellowship training at UCSF, where she will be co-founding the Global Surgery Institute. Via video, she will describe how to pursue an academic career in global surgery. Dr. Avital Harari is an endocrine surgeon at UCLA who has experience establishing educational opportunities for students and residents abroad. She will discuss the importance of a global health elective. Dr. Brian Remston is a pediatric cardiac surgeon at UCLA. He will describe his experience providing surgical care as part of a team providing humanitarian assistance to children with congenital heart disease. And finally, Dr. Reza Jarahi is a craniofacial surgeon who works with Dr. Bonnie Taub, an anthropologist, and chair of the Latin American Studies program at UCLA. Together, they received a UCLA transdisciplinary seed grant to examine how surgical care administered by foreign surgeons intersects with the cultural beliefs and traditions of the indigenous people they serve. So it's a rich menu. So, Dr. Chung.
Good morning. It's a real pleasure to be back here at my training grounds after being away for 10 years. I bring you greetings from Addis Ababa, Ethiopia, which has been my home for the last 2 years. Briefly, I have no disclosures. I graduated from the program in 2004. To give you an idea of where I slot into the timeline, when I first started the program as an intern, Dr. Joe Hines was my first chief resident. And when I finished the program, Dr. Busutil had just transitioned into his role as chairman. I practiced for 8 years with the Kaiser Permanente system here in Southern California. And I have a voluntary global academic appointment through Loma Linda University School of Medicine, largely through my work as a volunteer with the Pan-African Academy of Christian Surgeons, which I'll introduce to you this morning. This morning, in our brief time together, I'd like to give you a snapshot of the disparity of medical care around the world. I'd like to introduce the Pan-African Academy of Christian Surgeons as one model to help increase the surgical capacity in Africa, and if there's time, a personal perspective of my service in Addis Ababa. Let's start the morning with a little mental exercise. Just off the top of your head, what do you think the approximate ratio of inhabitants to doctors is in these various countries? A brief second there. This was an interesting map that came out a few years ago. And if you see in much of the developed world, there's about 300 to 500 inhabitants per doctor. In Haiti, for example, the poorest country in the Western Hemisphere, there's about 4,000 to 1. And then in sub-Saharan Africa, including Ethiopia, there are about 33,000 to 1. So you can see what a doctor shortage really looks like for the rest of the world. Despite this, there's a well-documented brain drain that's been happening from much of the developed world. You can see from these numbers from the US and the UK that a good proportion of these doctors come from very low-income countries. And this was a very provocative title from a New York Times Magazine article just a couple of years ago saying that America is stealing the world's doctors and that the US attracts more doctors than the UK, Canada, and Australia combined. And then for many years, malaria, TB, HIV have really taken the spotlight in global health, but more and more people recognize that a very significant portion of the global burden of disease can be treated with surgery. But as you can see from these numbers, it's very disproportionate. And in Africa, there was a paper a few years ago that said that in Africa, that surgery may be thought of the neglected stepchild of global health. So even in countries with better health systems like Kenya, you can see that there's only a fraction of the number of surgeons per population as recommended by the WHO. The Pan-African Academy of Christian Surgeons is a faith-based organization that is training African surgeons who will remain in Africa. And it tries to accomplish this through a 5-year North American competency-based residency. The applicants must be citizens of an African country, graduates of a bona fide medical school, be proficient in English, or if in a Francophone country, French, and have the recommendation and support of their home faith community, and agree to serve in the area of need upon completion. Now, I know that there may be skeptics out there when it comes to faith-based initiatives. I threw in this picture. This is a typical Ethiopian butcher shop with meat hanging, no refrigeration. I don't know how long the meat hangs up there. They may be nice, they may be Christian, but in the end, I'm not going to trust their meat. Or even in the secular humanitarian arena, we cannot accept substandard care to the needy. This fictitious article from The Onion, the satire publication, headlines "Doctors Without Licenses." So how is this program doing? Our program exists in 7 countries. There are currently 54 residents in training. Up to now, there have been 36 graduates. 100% of them serve in Africa, even beyond their time of commitment. And the goal is to train 100 surgeons, African surgeons, by the year 2020. We're on target for that goal. And we are recognized by the College of Surgeons in both West and Eastern Africa. In Ethiopia, it's the College of Surgeons of Eastern, Central, and Southern Africa. Furthermore, we receive our academic credentialing through the Loma Linda University School of Medicine. And in the country itself, in Ethiopia, more recently, my predecessors have worked very hard to get accreditation by the Ministries of Education and Health. Now, talking about Ethiopia specifically, the UN Human Development Index looks at the health, education, and living standards of various countries around the world. So I'll give you a second quiz. 186 countries had enough data to be ranked in 2013. Kind of think of where these countries might be listed. As you can see, the U.S. and our neighbor to the south does fairly well, and Ethiopia ranks fairly low, even below Haiti. Now, interestingly enough, there's a hospital run by Korean nationals in Addis Ababa. It's a 160-bed hospital, opened in 2004, and they applied to be a PACS training site in 2011. And understanding the cultural complexity there, the hospital is run by Korean administrators. The staff are largely Ethiopian doctors and nurses. And so the PACS program was looking for a Korean-American surgeon who felt called to mission work. And at that time, my wife and I looked at each other and said, I think this is our calling. So in 2012, prior to that, we sold our house. I resigned from partnership and raised support for about a year from various churches and friends and moved to Addis Ababa. As you can see from this picture, there are about 5 nationalities represented here. And I get all sorts of cases. I get lots of biliary disease. Unfortunately, there's no GI backup. There's no ERCP in the whole country, so biliary disease is completely a surgical entity. I see interesting cases like carotid body tumors, hydatid cysts of the liver, a lot of endemic goiter. This map shows where our graduates serve and where some of our trainees plan to serve in the very near future. Their training is largely dependent on financial support from the West and finding volunteer faculty who understand the competency-based, ethics-based model of training with graduated responsibility. And the strength of the program lies in that we're training African nationals in their home country and their home cultures, and our aim is to have our graduates take over the teaching duties in the very near future. So I hope I've given you a picture of the medical disparity in the world. I've really glossed over it. PACS is a very small, but up to now, a very effective program to train African surgeons with a competency ethics-based model. And perhaps later in the panel question and answer session, I can answer any questions that you might have about the cross-cultural challenges and the limitations of training with this model. I'd like to thank you for your invitation this morning, your attention, and I'd like to thank the PACS Commission, my missionary organization, Global Outreach International, and the various churches and individual donors who support our work. Thank you.
Good morning. I wanted to start today by defining some of the common terminology that is used in the global surgical literature. Surgery itself is defined as any condition that requires an invasive procedure to be performed on a patient, usually but not always requiring some anesthesia. This is a definition from the World Health Organization. You can see from this that the limitation of this definition is that it doesn't include any conditions that are potentially surgical, that often surgeons in the developed world are involved with no matter what. It is comprehensive in that it includes all surgical subspecialties. And what's also interesting is that it doesn't make any mention as to who needs to be performing surgeries. And in fact, this is a concept that is being used more and more in the developing world. I think it's useful to divide global surgery into 2 parts. When we think about surgery in low to middle income countries, there is essential and emergency surgery, which seeks to provide and give basic surgical care to any given population. And then there's comprehensive surgery, which seeks to improve the breadth and the quality of surgery being performed in low to middle income countries. So what is the global burden of surgery? This is something that's very hard to quantify because it transgresses all other components of the total global burden of disease, including communicable diseases, non-communicable diseases, and injuries, all of which surgery has a contribution to make. However, there are studies that have shown that of the 1.5 billion disability-adjusted life years calculated for the year 2004, on conservative estimates, surgical conditions accounted for 11% of this burden, with a big variety of contributions from injuries up to 12% and general surgical conditions such as appendicitis on a much smaller contribution. In fact, 6 conditions result in over 80% of the total surgical burden of disease, with, again, as you can see here, trauma and injuries accounting for the overwhelming majority of this burden. When we look at statistics that look at projected burden of disease up until the year 2030, we note that surgical burden of disease is actually projected to increase. And again, the biggest contributor to this is road traffic accidents and other traumatic injury. So how do we and how should we address the global surgical needs? And I think it's useful to compartmentalize our contributions into 3 components. First, the first thing that we can and should be doing is maximizing access to surgical care. The next thing that we should be looking at is minimizing cost and making surgical care as cost effective as possible. And finally, especially when it comes to comprehensive surgery, the quality of care that is to be delivered should be as optimal as possible given the local resource constraints. So what about access to surgery? Access and disparity is something that she already commented on. You can see there's huge shortages in workforce as well as infrastructure in low to middle income countries compared to the North American countries and Europe. In fact, Africa, that bears 25% of the global burden of disease, only has 2% of the healthcare workforce to help combat this burden of disease. And as again she mentioned, when we have this type of disparity and inequality in access, we get data like this, where if we were to divide the world's population into the richest, middle, and poorest third, and then divided the number of operations being performed annually, you can see the poorest 30% of the world's population only undergoes 3% of the annual surgeries. What about the cost of providing surgical care to low to middle income countries? And this is unfortunately a big unknown, partly because it hasn't been studied, as well as cost effectiveness of vaccinations or oral rehydration for diarrheal disease, but also because surgical care is extremely variable, and there's very cost effective and very cost ineffective interventions that can be performed. But what's promising is that there is a lot of shifting paradigms and a lot of innovative ways to make surgery as cost-effective as possible. And that's resulted in some of the perceptions of surgery in low to middle income countries being proven incorrect. As you can see from this slide, surgeries that were surgical interventions that were perceived to be too expensive are now on par with expenses due to measles immunizations or vitamin A administration in Africa. The notion that surgery can only be performed with high-tech equipment has also been proved incorrect, with innovative ideas such as using mosquito nets as hernia meshes and getting up to 3,000 pieces of mesh from one mosquito net, making surgery very cost-effective. And finally, as I had alluded to earlier, the concept of providing surgical care in the absence of physicians and surgeons has proven to be one of the most successful stories in several countries reaching the Millennium Development Goals, such as Mozambique, where 92% of maternal surgeries are safely and comparably performed without physicians being involved. This is just a slide that outlines some of the cost-effective interventions that have been published and reported on in terms of surgical services, including obstetric care, plastic surgery, trauma, and orthopedic care. Again, in comparison to oral rehydration therapy, many of these surgical interventions are just as cost-effective. What about the quality of surgical care that's being delivered in low to middle income countries? And this is my particular area of interest. You can see from the statistics here that surgical mortality is at least 10-fold higher than it is in the developed world. The mortality from general anesthesia is actually worse, with a mortality rate of up to 1 in 150, which is thousands-fold higher than what the mortality rate from general anesthesia here in the United States is. And what that results in is annually over 7 million perioperative complications and 1 million perioperative deaths, of which at least half of these are preventable. So these statistics had intrigued me, and my background and experiences in Armenia in the past had led me to try to develop some quality improvement measures in surgical care in Armenia. By way of background, Armenia is a small landlocked country about the size of Maryland with a population of 3 million people. Interestingly, more Armenians live outside of Armenia than they do in their homeland. As one of the most prosperous former Soviet republics, Armenia underwent a catastrophic economic collapse with the fall of the Soviet Union, with a huge drop in the GDP and resultant unemployment rates and poverty prevalence that is high and remains high to this date. Furthermore, the Soviet healthcare system, which was known as the Samashko system, literally collapsed and disappeared overnight with the fall of the Soviet Union. And this has left behind a series of problems that, again, the healthcare system in Armenia continues to try to tackle today, including things like corruption, informal payments, an inefficient system which actually has some of the opposite problems of other low to middle income countries, with too many doctors being trained, too many hospitals, and too much specialization and centralization that has taken place, again, because of the Soviet healthcare system. A virtual absence of any data that exists on quality of care that's being delivered, and a concomitant collapse of the education system, which has led to a huge decline in the quality of medical education and graduates. And so when we went to do a needs assessment in Armenia, we quickly discovered that the shortfalls in pediatric surgical care had less to do with emergency and essential surgery and more to do with creating a comprehensive surgical infrastructure in the country. And that's because, again, from the Soviet legacy, there was that the surgical infrastructure was there and most basic needs were being met. However, there was a lack of data to assess any quality of the care that's being provided, and the limited data and the anecdotal information that we had come across demonstrated clearly that there were major deficits in the education and training of surgeons, as well as a very high rate of complications that we had noted in visiting the hospitals. And so some of the projects that I've been working on and been involved with are as follows. We just recently, last week, had a pediatric surgery and urology symposium that was organized in the largest children's hospital in Armenia. And this was attended by faculty from several North American hospitals. Concomitantly, we've set up a laparoscopy training curriculum that has been validated by the folks in Toronto in Botswana, Africa, and now we're using this via Skype to train surgeons to become competent in laparoscopy in Armenia. We also, during this symposium, had a roundtable discussion and some breakout sessions to try to figure out what kind of projects we can implement to improve the quality of surgical care in Armenia, and we came up with the following list, which includes the implementation that we've now started on monthly online morbidity and mortality conferences to be moderated by pediatric surgeons from Europe and North America as a means to increase education and improve surgical quality. We've also established a continuous quality improvement committee that will be based in the Children's Hospital to try to identify pitfalls in quality that, in a collaboration with the American University of Armenia, we will be able to design interventions. And alongside this, in the new year, on January 1st, we'll be unveiling the prospective database that we'll be using to collect data on surgical care, pediatric surgical care in Armenia, which will hopefully help us identify other shortcomings that we can design interventions for. So in conclusion, surgical diseases are a major contributor to the global burden of disease, and this contribution will only increase in the upcoming years. I think it's useful to think about global surgery in twofold. First, with regards to providing access to care through emergency, to basic care through emergency and essential surgery, and this involves helping provide a surgical workforce as well as supplies and anesthetic help, etc., as well as thinking about comprehensive surgery, which is again my area of interest, which revolves around improving the quality of care that's delivered in low to middle income countries. No matter which option one chooses, I think surgical interventions can be proven to be cost-effective and sustainable, and no doubt surgeons will continue to have a huge role in global health. Thank you very much.
I just want to take a brief moment until the next speaker is ready to start to acknowledge the presence of Dr. Dean Washington, who was very kind to join us this morning to the time of his very busy schedule, and also to thank him for his enthusiastic support of the global health programs here at UCLA. One other special guest is Dr. Lee Miller, sitting there hiding on the corner, our incoming Vice Dean of Medical Student Affairs Associate. Okay, excuse me for that. Also very active actively involved with global health, and we're very pleased to have him with us this morning. Thank you.
Thank you. So I'll be providing some experiences developing an academic partnership in the main public teaching hospital of Mozambique, and also compare and contrast a little bit surgical missions and partnerships. So Mozambique, first of all, academic partnerships, there are a couple of principles. One is capacity building. Another is developing awareness of culture and context, ethical conduct, and of course, there's some sort of exchange, usually incorporating faculty and trainees. There are a couple of keys to successful and sustainable partnership. One, it has to be mutually beneficial, both for the visitors and for the local partners. And there needs to be an ongoing needs assessment to make sure that the partners' objectives and goals are being met. Now, Mozambique, in terms of the Human Development Index, is third from last. And it's a former Portuguese colony in Southeast Africa that's twice the size of California and has an Indian Ocean coastline the length of the Atlantic seaboard. And after independence in 1975, there was a mass exodus of physicians, so that in 2010, when I first got involved in the partnership, there were only 10 local pediatricians and 1 local general surgeon dedicated to pediatric care for the whole country, which was composed of 10 million children. So Lee Miller, who founded the partnership in pediatrics, had invited me to help provide training in pediatric surgery, and he's really inspired and mentored me to develop the surgical arm of our partnership. Through our partnership, we coordinated quarterly visits from U.S. surgeons to Proctor Atanasio, who is the local general surgeon dedicated to pediatric care. We provided textbooks, equipment, and other resources. And when I first arrived, he really had no formal training, little to no professional guidance, limited resources. We sent visiting surgeons who themselves had to learn a lot. They had to adapt to a patient population with a high incidence of malnutrition and infectious diseases, a different spectrum of surgical pathology with late presentation, and they gained perspective working in an environment where poverty contributed to disease, as in the case of burns from boiling water from low-lying pots accessible to unattended children and high fertility families, dilapidated infrastructure, but there was an incredibly efficient use of the limited resources as demonstrated with 2 operating rooms which are used simultaneously in the same operating room. There's minimal imaging and diagnostic tools, and those tools that are available when they break down have very little technical support to repair them. And also there's limited medications, so that the list here on the left of medications that are unavailable is longer than the list on the right of those that are available. Similarly, we've had to improvise. So I'm used to using a $10,000 Pena muscle stimulator to delineate the anal sphincter when doing a posterior sagittal anorectoplasty for anorectal malformations. We were able to use a 50-cent thermostat wire and a $200 anesthesia nerve stimulator to achieve the same goal. I think that these experiences for visiting surgeons, myself included, have made us less wasteful, more efficient, and perhaps more compassionate surgeons back here in the U.S. Now, both Atanasio, in the middle there, and Vanda, who was a resident when I first arrived and has now become a junior faculty member, have both visited UCLA. You might recognize their photographs and faces. And they've been able to observe differences in resource utilization, training programs, and teaching paradigms. They participated in international training workshops and conferences to acquire new skills. They presented at international meetings our partnership efforts, and they've been able to network with colleagues across the world globe and with colleagues within Africa. And they're currently establishing a pediatric general surgery training program to train the next generation of pediatric surgeons in Mozambique. So our educational exchange has involved medical students. There are a couple of students here who visited recently where I had the opportunity to go to the operating rooms. Shant, who visited 2 or 3 years ago with me, was able to help me perform a needs assessment and further our partnership efforts. In addition to training in neonatology, pediatric critical care, and other pediatric subspecialties, the partnership is now expanded to include pediatric anesthesia and pediatric radiology. And currently, Josina is here getting radiology training with Ines Beauchamp. So our partnership is also expanded to include research and quality improvement projects. The first project began with the clinical observation that patients appeared to be receiving unnecessary blood transfusions perioperatively, and anesthesiologists were canceling cases because hemoglobin levels were lower than 10, even for healthy patients undergoing minor procedures, this being quite frustrating to the local surgeons. And given the relatively high HIV prevalence in this population, and thus the higher risk of transmitting communicable diseases with blood transfusions, this was particularly concerning. So 2 first-year medical students worked with the local team on a global health education program sponsored SDTP research project the summer of 2012. And we were able to document that the majority of preoperative blood transfusions were avoidable based on recommended guidelines, and that the adoption of more restrictive practices could prevent several cases of HIV transmission per year, not to mention freeing up the limited blood supply for those patients who truly needed the blood. This work was presented at the Pacific Coast Surgical Association in Hawaii, was published in a high-impact journal, and led to a collaboration with the UCLA Transfusion Medicine Program, the CDC Mozambique, and the Ministry of Health. And we were able to now provide several training workshops in transfusion to physicians across Mozambique, and also provide a fellowship training for the future director of the Mozambican National Blood Bank through this partnership effort. Last year, our summer students helped review pediatric surgery ward and operative logbook data and demonstrated that 1/4 of the admissions were burns, 50% of which were infants and toddlers, and the majority of the patients received no operative treatment, resulting in contractures and disabling disfigurement. And the reason for that was that there was a lack of operative time and resources needed to address these burns in a timely manner. So since that time, we've donated dermatomes, and we have now sent a couple of surgeons to train in burn management, the local plastic surgeon, who's only one really for the whole region, and our pediatric surgical colleagues. And in the future, we hope to establish a burn unit and training center of excellence to help improve the operative capacity. This year, we've engaged local medical students to interview families to identify risk factors that contribute to the high prevalence of burns, with the goal of helping the Ministry of Health develop and implement prevention programs. Another student is working with general surgery residents on characterizing general surgery admissions and operative cases and looking at 24-hour mortality in a multi-institutional global surgery project. Dean Washington, we're very fortunate to have him accompanying us on a trip in August to promote our partnership activities with the U.S. Ambassador, CDC Mozambique, and the hospital leadership. And finally, we'll be piloting a general surgery elective this fall for a lab year resident. I do think it's helpful to compare surgical partnerships with surgical missions, which we often think of when we think of global surgery. They both have a role, and we've incorporated actually both models in our own partnership. Missions generally involve a surgical team. They provide direct patient care, and they usually measure the number of cases performed per dollar fundraise. Whereas partnerships are more focused on education, relationships, exchanges, and the metrics tend to be the number of providers trained, the number of lectures or workshops administered. Now, each has potential drawbacks. Missions are accused of being short-term work, a drop in the bucket in terms of management of population disease. However, for the individual patient who benefits from those surgical missions, it can have a dramatic impact. There's also issues of sustainability. The donated equipment may break down, supplies run out. Sometimes 2 surgical teams show up at the same time, so there's not always a coordinated effort. And of course, surgical complications are then oftentimes dealt with by local surgeons who aren't very happy with that. Surgical partnerships have the drawback they've been accused of being medical tourism, questionable benefit to the local institution, perhaps the visiting institutions getting greater benefit. There have been visitors who've been culturally insensitive, unsustainable technology's been introduced, and certainly some of these partnerships have contributed to brain drain. So I think we'll hear more about surgical missions and approaches and how they have integrated training using different methods in future talks. Thanks so much.
All right, so I'm going to be talking about my experience working with an organization. It's a 501c3 charity, hernia repair for the underserved, and it's a collaboration between the Liechtenstein Hernia Institute, the American Hernia Society, and it's most of the presidents that started the American Hernia Society, and us here at UCLA. And I include one of your co-residents, Dr. Wagner, because he's really become the educational director for the whole organization as well. We've really changed the paradigm for the last 3-4 years to where we're trying to foster sustainable change by changing the focus to a training model for surgeons. So we've talked a little bit about these things, so we'll gloss through them. So basically there's asymmetry in how and where surgery is delivered. A quarter of surgeries are so 70% of the population lives in a developing country, but only 25% of surgeries are performed there. And so the traditional response has been exactly this. This whole forum is to show how can we increase capacity? How can we make these things sustainable? How can we address infrastructure and long-term capacity? So this is the capital in Port-au-Prince, Haiti. You can see that infrastructure is definitely a problem from the top on down. So we've talked a little bit about this, that surgery is definitely part of global health. When we talk about disability-adjusted life years, the surgical burden of disease is 11%, so it's definitely significant. And surgical treated diseases they can be cost effective, as Shanta has shown. When we look at a dollar cost, so cost per surgical day is in the public health world, how we measure burden of disease and cost. So in regards to surgical care, and it depends what we're doing, but in low cost hospitals for certain procedures, it's on par with immunizations for measles and tetanus and home care for lower respiratory infections. So where is surgery helpful? So when we talk about what things can we do, the number one thing is, then there are 4 things. So prevention of death and disability from injury, and I think Katrina will talk about trauma care. Timely intervention of obstructed labor. So Diane Farmer came and talked to us, and she said anyone who's interested in doing global surgery, learn how to do a C-section, because that's what most people die from. Competent treatment of abdominal and non-abdominal emergencies. And then for what I do, so elective surgeries in certain conditions. So we know they can improve quality of life and productivity. So cataracts, patients can go back to work. Otitis media, clubfoot, hernias and hydroceles, and we also would include clefts as part of that elective surgery that really changes people's quality of life and their ability to work. So with regards to hernia, so it's the most common operation. So 20 million performed worldwide annually. It's irrespective of country, race, or socioeconomic status, and it's a major healthcare drain in every country. In regards to its benefit, it's meaningful to patients. They can go right back to work. For society, it keeps their society functional. There's direct tangible benefits. The nice thing for what I do and for what we do as an organization is it's safe. We can operate on patients. We know that they're going to be able to walk home. They can jump right off the table. We have not had really any complications. And the thing is that local superficial infections are the only thing we really worry about. And the things that we like are with if you want to train surgeons, it's great to have a complete model, but it's very difficult to establish that. So what we're trying to do is it's really a form of continuing education for practicing surgeons as well. So we can teach them reproducible techniques, world-class quality operations, and they can reproduce it with good outcomes. So, and this is definitely, with regards to hernia, cost-effective. So this is in the Dominican Republic. This is one of the Haitian patients. Both he and his daughter had surgery. So you can see this is right afterwards. he walked home. So they jump right off the table. We do it under local anesthesia, and they go home, and this is his home with he and his daughter right next to him. They both had surgery. This is their house, 1 bedroom, 8 kids, and so you can see how he needs to work, because otherwise that's their form of income. So our mission statement is that it's a nonprofit, and we practice the preferential option for the poor. So we want to provide free hernia surgery to adults and children, and we focus on the Western Hemisphere because of logistics. It's the same time zone. We can train the surgeons. They're not calling in the middle of the night, and we can get there. And it's an hour flight from Miami to get to Haiti. So we're all American hernia surgery surgeons. So we vet everybody. It's very selective about who we send out. Lots of surgeons want to participate. They come and they train with us first, and then we bring our anesthetists, and we basically, this is the key, that we say that we're going to perform the surgery exactly as you would have it here. Same mesh, same surgeons, same technique. So the organization started in 2003. First started in the Dominican Republic. We've expanded to over 10 sites, performed over 1,800 hernia operations. And as Dan said, this is nice for 1,800 people, but the burden of disease is much greater. So we really have tried to expand that into training, and that's what we've been, Justin and I have been really working on that in the last 3 years. So this is the sites that we go to. You can see that a lot of where we're investing our time is Haiti, because it's the greatest need in the Western Hemisphere. We are also doing the same things. We set up some in Brazil. You see, this country is not like the others. This is developed world, but there's a tremendous disparity. So what we're doing is we're training rural surgeons, bringing them into Sao Paulo, operating all at the same time in the charity hospital, and then sending them back out and proctoring them. This is Dr. Philippi. He's a professor emeritus at Creighton University. He started the organization, and this is, you can see, with one of the kids. So the goal is we've tried to implement a model for training local surgeons committed to technical excellence, and really to foster them in their own academic careers so that they can succeed and be inclined to stay in their own countries. So this is in Haiti. You can see. So we try to, it's the concept of training trainers. So we've trained 19 surgeons since 2012. This fall, we're ramping that up, so we'll train just this fall, we'll double that and train 20 in Brazil, Paraguay, Guatemala, Haiti, Dominican Republic, and 2 sites in Haiti. So it's a formalized system for training. They get a certification of participation. We provide ongoing mentorship and support, and then I'll talk about some of these new things that are exciting that really, because we have Dr. Wagner involved, we can do these virtual campus things, teleproctoring, and really leverage technology to accomplish these things. So some of the Haitian surgeons, so we have a defined lecture series. We post the lectures right onto our website. They get sequential proctored cases. So we know for surgeons, you can do 5 cases with a Liechtenstein if you're a trained surgeon, and you'll be pretty good at it. Stepwise training, we teach under local anesthesia. Here's Dr. Wagner operating. And we use the OPRS, so exactly what you guys are getting here once in a while, we're using out there with our surgeons. So here's the operation. Right after, we go over with the forms, and just like we would do here. And you can see that Dr. Wagner translated our UCLA system right onto our website here. So you click on, and here's a Liechtenstein operation in Spanish, in French, in Portuguese, step-by-step on procedure-specific criteria, general criteria. And then here we track everyone we've trained, Google Docs, free. This is all free platform. I can then plug in Dr. Jacques. We trained him in the DR. He's a Haitian surgeon. This is how good he was on individual operation. This is how good he was over 5 operations. And by the 5th one, was he competent? We go over, this is in Paraguay, we're going over with a surgeon right after. This is how you did on the day. In Haiti, we then give him a certificate. And then Justin developed this whole system where surgeons can now track their outcomes. So then now they can think of the way that we do. How can we improve quality? So every surgeon we've trained has their own little folder. They log their cases. When they log their cases and track their outcomes, we give them mesh. So we provide them with more mesh. So 19 surgeons have been trained. They're all competent. We know that so here we can now mentor them. So how do we then follow them? So 2 big projects in the fall. We've teamed up with the Ministry of Health in Haiti. It's 38% of the disease burden and 40% of general surgery of their volume in Port-au-Prince. So we've signed a memorandum of understanding. For 5 years, we're going to train the next generation of academic surgeons for hernia repair so that they'll be able to take care of their own needs. In Brazil, same thing. We're taking the rural surgeons, bringing them into University of Santa Casa in Sao Paulo, and then we'll try and fill the gap that way. So mesh, you talked about mosquito net. Definitely it works. It's polyethylene. Not as good because over time it fractures, but definitely better than a tissue repair. We've tried to partner with industry, and that's the goal, is that in the work of global health and charity, you want as many partners as possible. So here's one of the surgeons I trained in Haiti. This is his OR. This is where he operates. He does laparotomies in here, just in a room in his own clinic. And here's us coming back, and we're bringing a mesh back to Haiti. So these are some of the neat things that are coming up that we've been doing. So you've heard a little bit about us using Google Glass, mainly to get some excitement. It still has some kinks, but it works. And so here you can see, this is a operating room in Haiti that was set up by Sages. Cost several hundreds of thousands of dollars, about $250,000. Cisco built it, Storks built it. You can train laparoscopic surgery. But for $1,500, we brought Google Glass down to Paraguay and Brazil. I'm going to leave it in Haiti, bring GoPros, and you can do the same thing. And we live stream it for free. And these are technologies. Someone else built it to connect the world. And so we're leveraging free technology to do these things. So here's live streaming from Paraguay, and the one right before, and then this is in Brazil. This is out of Santa Monica. So this is the Santa Monica boardroom. So this is 2 hospitals in Haiti. This is Cap Haitian, and this Port-au-Prince. Teleproctoring, we give a lecture, 2 grand rounds. And so we can do this we can beam from any OR at UCLA. We can beam from any conference room. It's really fantastic. So we can address this brain drain without leaving your office. So the other thing, here's Facebook group. We have 692 surgeons. I helped start this with another surgeon. And so surgeons on it, silent industry partners, they can watch over 60 countries. And so this is that day in Haiti. I asked, how many of you have a Facebook account? Everybody. Yeah. The same night, so this lady came in from the countryside. What do we do with it? We want to put in mesh. We want to do component separation. Immediately, Switzerland, Pakistan, surgeons, there's 40 responses. Don't do that. Do this. It's amazing. You just connect people. So no surgeon is alone. When you finish, we always worry about, how do we help people still? So these are things that we can go right off of Facebook, right off of Twitter. And so this is technology being leveraged to accomplish these goals. So this is a high-impact humanitarian outreach. It's cost-effective, well-delineated training. We partner with everybody. It's a charity. And we try to all benefit together. And so as Dan said, we don't want simple charity. You actually undermine the local population. So we want to train trainers. We want to create experts. We want to create centers of excellence and infrastructure. So this is, you can see how resourceful. This is a USAID box, and this kid's making it into a toy in Haiti. So it's pretty amazing. And so, I have the luxury of being trained by amazing people here. And so, I have the responsibility to do the same thing, as I hope all of you do too. So.
I'm Katrine Juilliard. Thanks for letting me talk today about how I developed a career in academic global surgery. I'll first talk a little bit about how I got interested in global health and then how I turned that into my primary academic focus as a surgeon. Hi, I'm Katrine Juilliard. Thanks for letting me talk today about how I developed a career in academic global surgery. I'll first talk a little bit about how I got interested in global health and then how I turned that into my primary academic focus as a surgeon. It all started for me when I decided to join the Peace Corps after college. I was assigned to a small village in Senegal, and this is what it looked like when I got there. It was a village of about 250 people, no running water, no electricity. This was before internet and cell phones were really widely available. And I lived in a mud hut. And what ultimately happened was the people that I lived with became not only my friends, but almost like a family to me. I learned their language, and I also learned what it was like to not have access to health care. And especially surgery. So when I decided to go to medical school, based a lot on this experience, I also decided to become a surgeon. And I started looking around at what had been done from a public health perspective about surgical problems in low and middle income countries. And not a lot had been done at that point. There were some very amazing people who had pioneered the field, but there was not a huge body of literature. And I quickly realized that if I wanted to contribute, that I would have to get formally trained. And to me, that meant getting a master's in public health. So when it came to time to craft my research years at UCLA, I knew I wanted to get a master's in public health, and I wanted to go to a program that had a strong international reputation and that I could have a strong network through. So I looked at the student body and made sure that there were people from all countries all over the world there. And I also wanted someplace that had a really strong mentorship in what I wanted to do. And that ended up being Johns Hopkins for me. So I spent a year there doing my master's in public health, and I spent a few months during that summer afterwards in Geneva at the World Health Organization, working in the Department of Violence and Injury Prevention with a man named Charlie Mock, who's not only a trauma surgeon, but a very talented epidemiologist. And then with mentorship in both of those places, we created a project in Cameroon where I spent my second year. Now, all research can be really frustrating and challenging, but I think global health has its unique challenges. First of all, if you're doing something in global surgery, you're part of a body of people who are forging a new path, and that can be hard to explain to people who haven't been exposed to that kind of research before. In low and middle income countries, there are uncontrollable delays beyond what we experience here in the United States, and there are cultural differences which can be tricky to navigate. And finally, the relationships with low and middle income country partners are probably the most fundamental part of any success in this field. And maintaining those relationships once you're no longer in the country can be very difficult. Many of my partners in Cameroon don't have access to internet on a regular basis, and sometimes not even phones, so it can be hard to keep those relationships going, and they're crucial for success. Now, this is getting an IRB at Hopkins, and this is what it looks like getting an IRB approval in a country like Cameroon. So you can see, it took me a while, it took 6 months for me to get all the approvals I needed to start my project. And during those first 6 months, I spent a long time thinking about how I was going to come home empty-handed and Dr. Hines is going to be mad at me. So in order to minimize the Cameroon to do project, I knew I needed to focus on any opportunity I had. So I had to draw from a wide base of mentorship that was available to me both at UCLA and Johns Hopkins. And while there wasn't the perfect mentor because it was such a new field and not very many people were doing it, I did have access to people who were experts in their own right. So people like Dr. Pryor, who's an academic trauma surgeon who's nationally known and very successful and who's mentored me tremendously and professionally through the years. And people like Dr. Hines, whose leadership really helped me have the opportunity to do what I did during my research years. And people like Dr. Poe, who when he was first coming out, really forged a new field in his own right. And even though it wasn't the same field that I wanted to enter, knowing that he had done something new and different, I could draw on his mentorship to do the same in a different direction. Similarly, at Hopkins and UCSF, I was able to find mentors, and I'll talk a little bit more about my mentorship at UCSF in a bit. Now, similarly, imperfect projects may turn out to be great opportunities. So there may not be the project that's exactly what you want to do with your life, but they may provide an opportunity to learn something that you'll apply later. And that was something true for me. And being at an institution like UCLA or Johns Hopkins, there are a lot of opportunities, which is one of the great things about being in a place like that. So as a general surgeon, I wasn't exactly thrilled with the idea of being lead author on a hysterectomy paper. It wasn't exactly at the top of my research agenda, but I took the opportunity, and actually it was a great learning experience for me. I learned a lot about biostatistics, and I did get to be lead author on a paper that was ultimately published in JACS, so that was really important for somebody who was just starting a research career. And similarly, things like taking a class on injury prevention at Johns Hopkins, I, at the time, was not sure I was going to go into trauma, and I kind of thought safety was for nerds. So I wasn't super keen on it, but some of the other students taking it said it was really interesting, and I ended up taking a bunch of injury prevention classes, and they not only convinced me to become a trauma surgeon because I saw how important it was, but it also became the foundation of my research, so it actually changed my career path. Now, one of the most important things in establishing your academic career is academic output, and publications are a key component of that. So I really tried to turn anything I did into some sort of publication. When I was at WHO, I worked with Dr. Mock, and we wrote 3 books, which opened a lot of doors for me, because later on people that I met were familiar with work and I got opportunities to do that. And then really peer-reviewed publications are obviously very important. So anything I did, biostatistics, projects or literature reviews, I tried to turn them into a publication. And that really helped me feel like I was creating output even when I was waiting for IRB approvals and fearful that my project was going to fall through. Now, while academic output is important, I think that all of it is really leading to the most important output in my mind, which is creating change. And we were able to do that in a small way in Cameroon. When I was chief resident, I went back to Cameroon and my partners there and I presented our findings from our study to the Ministry of Health. And we were able to argue that trauma was a significant burden of disease in Cameroon and that people were using surgical services at a high rate, people who were injured, and that those services weren't well funded by the Ministry of Health or outside funding. So the Minister of Health, in response to our findings, recommended to the Prime Minister that he create an injury committee. So he made a decree and that was done. And we're now working with that injury committee in Cameroon to expand our trauma registry so we can find data-driven policy recommendations for injury prevention and quality improvement at the hospital level. In terms of the next steps, we've done a lot. People before me mostly have done a lot in terms of establishing the epidemiology of surgical diseases in low and middle income countries, but there's still many countries where we don't know very much, so there's still a lot of work to do. And in terms of measuring disability, I think we need to improve the way we do that, especially for surgical diseases. Trauma is a prime example where what doesn't kill you might injure you severely and leave you disabled or unable to work for long periods of time. So capturing that burden of disease is important to advocate for resources. Quality improvement in low and middle income countries is not well defined, and we don't have good ways that are evidence-based in terms of how to improve quality surgery. So there's work to be done there as well. And finally, cost effectiveness analysis is probably one of the most important ways to put anything on a public health agenda. So we have plenty of work to do there because unfortunately many people think that surgery is not cost effective, but the little we do know is pointing towards the thought that it is. So I think there's a lot of room for improvement there to help advocate for improving surgical care. Finally, I really want to thank all of you for allowing me to speak, especially Dr. Dave Garte, who is a tremendous mentor available to you now. I wish he had been available to me when I was a resident. He hadn't come on faculty yet. But I did have the benefit of having Dr. Hines' leadership, and I'm very grateful to him for all he's done to support me, and Dr. Pryor, who's been a tremendous professional mentor for me. And then my mentors at Johns Hopkins, Charlie Mock, and my partners in the low and middle income countries where I've worked have been incredibly supportive and helpful. And finally, Dr. Dacre Rochelle, who's in the center top of the pictures, is one of my main mentors at UCSF. And she and I'm joined the faculty at UCSF, and she and I successfully advocated and applied for funding from our chair, Nancy Asher, to start a global surgery institute at UCSF. So we'll be doing that in the next few months, and there'll be a center for to centralize all the people who are doing global surgery research and to formalize a fellowship track for our residents and fellows who want to pursue that as their academic focus. And with that, I just thank you for your time, and please feel free to email me with any questions or thoughts.
Stretch. Good morning, everyone. Very excited to be speaking here today. Thanks to RT and Dan for setting this up, and to Dr. Coates for moderating, and to Dean Washington and Dr. Busatil for coming here to support us today. I wanted to talk to you about the importance of exposure to global surgery during training. And to explain why developing global health programs has been such an important passion of mine, I wanted to take you through my global health journey. So my journey started when I was 15. Back in the summer of 1993, I spent most of the summer doing research at the Technion Institute of Technology in Haifa. This is like the MIT of Israel. And even though initially I would rather have been on the beach, the summer ended up changing my life. I was involved in a project with a pediatric surgeon doing surgeries on dogs that he would later do in kids with short bowel syndrome. This was my first exposure to surgery, albeit in a dog,
but it affected me greatly and sparked my interest not only in medicine, but in surgery. So the itch to know the world better was always there. Between undergrad and med school, I backpacked around the world for about 9 months. Curious about hospitals in these countries, I spent a couple of days and randomly showed up at hospitals in India, hoping someone would show me around. I was welcomed with open arms. One of the doctors even invited us to his home. This was my first exposure to the long wards of hospitals in the developing world and countless patients who had to sit on the floor or share beds since there was not enough room. I realized then not only how generous and kind the doctors were, but how disparate the care was. This didn't seem fair to me, and I knew that part of my mission in life would be to help equalize care amongst nations. Despite my young age, that experience alone had a huge impact on me. When I began medical school, I searched for opportunities to go abroad during my first summer. There were no such opportunities. I joined our medical school international health group, and through this, I was able to create the first summer global health elective at my school. I approached the dean for funding, and he agreed to pilot fund 5 students. So that summer, I went off to Lima, Peru, and 4 other students went to other parts of the world. This was so widely successful that now, every year, 20 students go abroad, and they're all fully funded by the school. So in Lima, I spent the summer at the Gringo House, sharing a tiny house with 10 other people. Over the course of the last 14 years, I have met people in random places of the world who have spent time at this house, one of whom is sitting in this room. Here I am, and you might recognize this lady. Elise and I met each other 14 years ago and did not see each other until I started here at UCLA. The global health world is a very small world. I spent the summer doing epidemiology research with Dr. Bob Gilman from Hopkins in the shanty towns around Lima, Peru. We collected stool and blood samples from kids under age 3 to see what the prevalence of H. pylori was in this population. This was Dr. Gilman's huge team of people doing amazing field and laboratory work. And this was my first exposure to conducting research in the developing world. It's very harrowing. Things just do not move at a pace that we in the US are used to. It was an important lesson in patience and in understanding why change is so slow in these countries, even when the best intention is there. But why is it important to expose medical students to global health, and why surgery specifically? There's been a paradigm shift in global health. Access to surgical care is no longer considered a luxury, but instead has been seen as a critical component of health. Medical educators have incorporated global health into the curricula at most medical schools, and student leadership has played a large role in the development of the global health curricula. The list of benefits of a global health elective to medical students is long. Most medical schools find this elective opportunity to be critical in their curriculum. These opportunities offer medical student exposure to a wide variety of cases, working with limited resources, cost-conscious practices, and nurture an interest in providing care to the underserved throughout their career. When I first arrived at UCLA, I was actually fortunate to meet Dr. Lee Miller and Dr. Coates and got involved in the creation of the UCLA first-year summer abroad program, as I had done at WashU. I was very excited to hear that UCLA Med School was embracing those opportunities for the medical students. So later in medical school, I decided to go to an international 4th-year elective in surgery. No one had done that prior to me, and as most opportunities were in medicine or HIV. And I wanted to see how I could incorporate global health into my career as a surgeon. So I developed a surgical rotation at the University of Ghana in Accra, the largest hospital in West Africa. This was an incredible opportunity. The surgical team I worked with was skilled and amiable. They were amazing teachers and gave me the incredible exposure not only to vast surgical diseases there, but also the nuances of practicing surgical medicine with wide constraints. I then entered residency, where once again there was no option to go abroad as a surgical resident. The medicine residents had long since set electives set up, which was the case for most medical schools throughout the country. At the time, there were only a few institutions that offered surgical global residency electives. And given my experiences, I felt really strongly that to get this opportunity to the residents. But why is it so important? It's estimated by the WHO that by 2030, the surgical diseases will contribute significantly to the global burden of disease. We need to therefore train our residents to understand our responsibilities for equalizing surgical care in the world and to ameliorate barriers of access to care, not only to the developing world, but in our own nation as well. Offering these electives also benefits the residency programs. They will not only train residents to rely less on expensive tests and equipment and further develop their exam and communication skills, but at a basic level, programs that offer this will attract a broader applicant pool. However, setting up these programs in surgical residencies has a lot more challenges not seen by medical student observerships. Setting surgeons to operate abroad is not simple, and making sure that the local institutions that host our trainees are gaining from that experience is very critical. So what did the residents get out of this? They develop skills in practicing in resource-limited settings, learn about worldwide disparities in care, gain insight into different cultures, health beliefs and pathologic conditions, and learn to see issues in our own society from a deeper, different, and broader perspective. And something that really drives me to create these programs, it encourages new leaders in global health and interest in providing care to the underserved throughout their career. So at Columbia, after some lessons in politics and perseverance, I was eventually supported by the chair and the program director to develop the Global Health Surgical Elective. I then set off to visit sites in India, in the Philippines, and in the DR as potential new sites for the program. The goals for the program I was developing were broad but deep. These are the same goals we're using now as we developed our program here at UCLA. And these are to create a mutually beneficial international academic partnership with universities in low and middle income countries that promote collaborative clinical research and educational exchanges. Provide representatives from both the U.S. and partnering institutions with clinical and research experiences that promote humanism, increase breadth of medical knowledge, and lead to careers in global health. Initiate sustainable research programs that benefit both institutions and elevate further our reputation and recruit top graduates to residency. With these goals in mind, I set out for KEM Hospital in India, a tertiary care governmental hospital in Mumbai. There I spent a week with Dr. Jignesh Gandhi, who eventually spent time at Columbia as well, seeing how the surgical department there functioned and to see if it would be a good match for our program. Once again, I saw the wards and the waiting rooms overrun with patients, their OR, complete with a random, not so sterile open access door to the next OR. That week, I saw TB enteritis, infectious leg disease, large sarcomas, and this, which I think is a hydrocele. Not so sure. I then flew over to the Philippines to see a governmental hospital there. The experience was similar, and they were all very welcoming. I soon realized that surgical care received in most of the developing world was similar, as were the advanced disease that we would see for most of the patients. This one is my favorite picture. We need to get these gowns with pockets. In that week, I saw large breast masses, fungating tumors of the breast and chest, and of course, my fair share of neck masses. I realized that any of these places would be a great place for our residents to experience. When I got back, we applied to the local GME, who approved a way elective for the fourth-year surgical residents. The chair provided funding for up to 7 residents a year. Unfortunately, the program director did not share my vision of developing a strong, consistent relationship with one institution, so the program developed into more of a program sending residents to several places in the world. But it is very successful and continues to this day. So this brings me to UCLA. When I got here, I also saw there was no opportunity for the residents to do an international rotation. And for the same reasons I mentioned before, I thought it would be very important to offer that to our residents as well. Unfortunately, Dr. Hines has been very supportive to the idea from the beginning. The same goals applied, but this time I placed a stronger emphasis on partnering with just a select few institutions so we could participate not only in residency teaching, but also in local capacity building. I started working with Joe a few years ago. The national GME since then approved an official surgical international elective, but their rules were stringent and if it was going to be official. This was difficult to achieve mainly because of the requirement of having an American board certified or an equivalent surgeon to supervise the residents abroad. This has hampered us a little bit, but many programs in the country do not offer this as an official rotation given these constraints, and they send the residents within their lab years. The Columbia rotation does continue in its clinical year, but it is unofficial, which is maybe what we might end up doing. I started working with Dr. Bill Schechter to create a new global health committee at the Pacific Coast Surgical Association. Dr. Schechter is at UCSF. He spearheaded the development of the consortium of PCSA universities to partner with an institution in Tanzania, Africa. This has become widely successful and is going to be one of the opportunities that we'll offer to our residents in the year to come. In the past year and a half, Dr. Dan Diogarte has also become part of our group developing the curriculum for our residents, and as he develops the one for the medical students here as well. This year, we had finally enough details laid out that we were finally able to approach Dr. Bustil for financial help in supporting the general surgery residency elective. Dr. Bustil and Marshall Morrissey spoke with Dean Washington, who is equally supportive of global health programs. And we'd like to thank these three very important people for giving us pilot funding to spearhead this program in the year to come. The funding will cover all travel and related expenses for both faculty and residents involved in the programs that I will mention in the next slide. The pilot seeks to fund 1 to 4 week electives. The opportunity is now only open to lab residents, since the fourth year doesn't have an elective, but hopefully we'll build that in sometime soon. The application is now officially online. So lab residents, please apply. She can send out this website link after today. And the programs available are the PCSA in Tanzania that I'm spearheading, Dan's program in Mozambique that you've heard about, Dr. Chen's program in the hernia mission trips, and Chant's program in Armenia eventually when he gets it set up. Tanzania program is called the Alliance for Global Clinical Training and Surgical Education. It involves multiple West Coast universities, which partner with this tertiary care center at Muhimbili University in Tanzania. The main goals are capacity building with resident faculty cross-teaching, exposure to the residents, to a breadth of elective and emergent surgical cases, as well as development of research projects. Surgery, anesthesia, and nursing are all participating. This is the rotation for the coming year. As you see, we have representatives from UCSF, OHSU, UCSF East Bay, Kaiser, and now us. In November, we want to send a resident and a faculty member there. I'll be delivering at that time, so I think Ali Chiedo is probably going to be the one we send with one of the lab residents. I'll go there the year after. And if any faculty member is interested in this trip, please let me know. I welcome also the lab residents to apply to this and the other rotations. Just a peek at the institution. This is Dr. Peck in the background. And just some examples of the types of cases you'll see and perform in Tanzania. Thanks for allowing me to share my story and this new exciting program we've developed at UCLA.
Good morning.
Good morning.
Please excuse my attire. I had a little early morning excitement. I just got done with. My name is Brian Reamson, and this really should have Chuck Alejos' name here because number one, I stole these slides from him, and number two, he's really the founder and the soul of Hearts with Hope, and I'm just a small part of this great organization that I'll talk to you about. Our mission is to provide medical and humanitarian assistance to children in Latin America with congenital heart disease. First of all, the need for this is dramatic. And as you can see, places like Brazil and Colombia, their population is high, but they have a reasonable amount of surgeries performed. But places like Peru have again, a smaller population, but the number of cases actually performed are minimal. And usually they're the most straightforward, simple cases. So those with more complex lesions go untreated. If you look at this is another of the surgeries not performed. You see Peru has 81% of the kids that could have or would have congenital heart surgery here in the United States go unoperated. And obviously this doesn't just affect their lifestyle, it affects their lifespan. And so these children will die from their cardiac lesion. So the accuracy of these numbers is also in question, and it's probably far underreported. Most of the reason is because in the mountains and rainforests, no one knows if you have congenital heart disease. And there's a failure to diagnose, and there's no echocardiograms, obviously, along the rainforests. So really all four of these are responsible for a failure to diagnose. There's insufficient pediatric cardiologists, which really there are none, especially in the remote areas. Insufficient equipment, meaning echocardiograms or even stethoscopes. Insufficient access to equipment. And then even if they have the equipment, they would have insufficient training. So it's multifactorial. So where did the Hearts with Hope begin? Why do it, and why choose the sites? Well, it began with Chuck Alejos, like I told you. He is Peruvian, and obviously he has some personal reasons. And also the need we talked about in Peru is one of the most underserved, or the kids there with congenital heart disease go unoperated almost more than any other country in the world. And then choosing the site, I'll go through. So how to prepare for a mission. First of all, you have to locate a facility. They're very proud people, but they have to want this to happen. You can show them the statistics, but they have to buy in, and I think that's one of the most important things. You have to identify physicians on the ground. You need people. You can't just bring a bunch of people in there, do the surgery, and leave. You have to have people setting up well before we get there, and then taking care of these kids once we leave. So it's a very important thing to have physicians on the ground that obviously are as vested as you are. Identify patients. We can't just, we have to start operating the day I arrive, and so we have to have these patients worked up and ready to go. Locate suppliers, transportation and lodging, and a lot, obviously, as shown before in these countries, there's a lot of paperwork to get through. And this is us being welcomed by a group called FASAL, I'll go through, which are physicians and non-physicians that help us go through everything. They take us, they provide transportation, they give us lunch, and without them, we really wouldn't be able to do this. So Hearts with Hope started in Arequipa, which is a small town here in the south of Peru, population of 100 million, and it is at altitude. And the hospital that we work at is mostly an adult, but also a children's hospital. And there's 14 orphanages and schools where most of the patients are found. This is one of the kids that I actually operated on. She's a very robust young female, but she had tetralogy. We find that these kids are self-selected. They're tough. They've made it to this point. Otherwise, they wouldn't make it this far and get through this very complicated surgery. Obviously, and the focus of my talk really is the teamwork. And again, that's what I've talked about, is locating these folks in Peru or any country that want to do this as much as you do. And Dr. Lejos is with Pedro Torres. They have started Hearts with Hope, and FASAL came on, and this is, again, the support group that helps us with kind of the non-medical portion of it, and they are integral to our success. And it started out as a 10-year project, and it's getting past that, and there's a new direction I'll talk about going forward. Here's another child that I operated on. He just had a simple VSD. So first of all, gaining the trust. And what the gaining the trust really is a long-term commitment. They just don't want you to go down there as a mission and then leave. So we actually, and Dr. Lejos is in a constant conversation with them through the year, and they want us to expand to other cities, and not only in Peru, but also in some of the other countries I'll talk about. So Hearts with Hope was founded in 1995, incorporated 2006. We've had 4 missions to Lima, and Arequipa had 6 missions, 6 surgical and 3 EP. We've gone to Lima, Peru on 2 missions, and El Salvador on 2 missions as well. So this actually is not the most recent. This cardiac surgeries are about actually 120. Catheterizations are about 230. But you see this dental evaluations, fluoride treatments and fillings, and so the medical evaluations, which are so important as well. So it's not just surgery, but it's a wide encompassing care for these children. So teamwork. This is me taking a surgical assistant through an ASD on one of my last trips. And when you think of teamwork in the operating room, you think of your surgical assistants, the perfusionists, and the nurses handling the equipment. But really, it's all the people that you don't see in this picture that are the most integral parts to this teamwork. I'm a very small cog in this huge wheel that does this very complex surgery. And the other team members are families, not only at home, that when we take a week of our vacation, and many times nurses take 2 weeks of their vacation and pay $1,000 for their ticket to go down there. So the families our families here and obviously the families there, giving their most precious possession to you and trusting you that you're going to operate in a successful manner. Obviously, industry is a huge part. Cardiac surgery, the reason they don't do it there is not that they don't have the technical ability, they don't have training, obviously, but cardiac surgery is the most expensive surgery probably that there is. And just with the pump and all the disposables, we need industry support because it's, again, we have to take all of that equipment down there with us. Obviously, our home institutions that support this as well. So sometimes anesthesia can be a hands-on method here, and this is a child that's just getting some blood taken. But when they go out for these medical missions, and especially the dental, because they're usually extractions, anesthesia plays a big part. So we really want to train the physicians side by side and really proctor for interventional cath. It's not likely that they'll ever actually do the cardiac surgery, again, for mostly because of the expense. We want to act as consultants in cardiology rather than the primary care physician. And really, the most important thing is a long-term commitment to these people. And this is the ICU, following things, very, very busy place. We do a couple of cases a day. They're usually ventricular septal defects and tetralogy, especially at altitude. We don't do a lot of single ventricle. We will do much more complex stuff. One of the biggest things is the blood bank, and because if there is any bleeding, there's a limit to their capability, obviously. And here's the two kids. They are almost, like I said, right on top of each other. We have a 4-bed unit, and so when we do the surgery, these kids are extubated in the operating room on no drips, and they usually go home in about 2 days. And so it's a real process to get these kids because there's limited space in this hospital. So stumbling blocks, obviously the need exceeds our ability to provide. There are politics from the hospital. We had a mission set up, and there's a region-wide nursing strike, and we had to abort the whole thing, which is a big deal because a lot of people have taken their vacation and bought tickets already. And availability of equipment, like I said, we rely on industry now, but obviously that bucket may be empty at some time. And sometimes we have to sterilize our own equipment. This was early on. We kind of stopped this, but we do leave whatever we take down there. We actually leave if they want to use, and they will re-sterilize a lot of the equipment that we've used previously. So the future is that obviously Machu Picchu wasn't built in one day. Want to do, Chuck is trying to do a Hearts with Hope that's international and have other places that we're going to go except for Peru, besides Peru and El Salvador. And there's a group of kids that they're very thankful people that actually we had operated on for the past few missions. And they came, threw some banners. Again, Hearts with Hope, upcoming missions. Actually, I'm going to Arequipa 2 weeks. 2 weeks. But the coming up also in the spring, April 26th, El Salvador in July, and Lima in September. We're looking at other places, again, in Peru, Cambodia, and the Philippines as well. Who's eligible? Pretty much anybody. Residents, fellows, nurses, respiratory therapists. So if you want to get involved, it's a fun and very rewarding couple weeks of your life. Thank you very much.
Leave your ballots for the best beard contest on the way out. We've had an issue.
No chance.
Yeah, right. Uh-huh. So I also want to add my thanks to a bunch of people because what the students maybe in residence fail to recognize is that what you just seen is very artificial. People aren't necessarily enthusiastic about faculty members leaving their home institution and going overseas and taking that brain drain away for that period of time. So from people like Dr. Bustil, Dr. Hines, and Dr. Washington, who are supportive of their faculty members going overseas, to Dr. Economou, who helps provide research funding, which I benefit in my case through a transdisciplinary seed grant, to all of our mentors, one of mine, Jorge Lazareff, in the audience, and to Dr. Talou, who gives us this forum to describe our experiences to you, hopefully inspire you in some way. And most importantly, to Dan and to Abital for their leadership roles, and to all my colleagues who presented today, because it is a small world in global health, and it's all a series of tough acts to follow, so I don't pretend to provide any astonishingly innovative insights, but I do want to take a different tack. I'm sorry, I forgot to also mention the sort of vision of Tom Coates and Lee Miller, who've now organize us in the Center for World Health and are really, I think, going to, kickstart this program and drive it into high gear and recruit people of all levels, from faculty down to medical students, and really bring UCLA to the forefront of this effort in the U.S. My perspective is something that my colleague and I, Dr. Taub, who's the chair of Latin American Studies, have started to call surgical anthropology, and it's not something that's really those terms aren't really found together in the literature too much, and we're hoping to start introducing this terminology. We have done so far at several meetings. The American College of Surgeons coming, the Southern California chapter, and the American Surgical Congress. Some lofty objectives for 10 minutes, but basically I want to describe my perspective and experience at the intersection of medicine and culture in Latin America, and why I feel that's important. So all of us, we've heard of all the data, and we know that there's a need in the developing world to help provide people who are underrepresented and lack access to even basic surgical care, much less sort of highly technical surgical care like Dr. Reemson just described. We know there is that need, and those of us who are engaged in this, I think we start with the question of how can I help? What can I do to address the problem? How can I contribute? And we all have our skill sets. Brian can go and do an open heart surgery on a child. I can go and I can fix a cleft lip. No big deal. I can take a child who was born without an ear. I can take cartilage from the chest, carve it into an ear, and give the child an ear. That's sort of my skill set. So that's how I feel I can contribute to children who are born with congenital craniofacial deformities or any other plastic surgery acquired disease for that matter, and sort of make an impact on the small scale of that child and their family. Excuse me. So what's the context how we provide this care? And I think what you've seen today is very unique and very special. And it doesn't exist universally yet, although I think, again, with the guidance of Dr. Coates, this is where we're headed. But right now, I call it sort of the parachute model. So you get a team of physicians, surgeons of different specialties, anesthesiologists, administrators, supportive staff, and you fly in. You get on a plane, you drop into a locale, somewhere in the developing world, on some continent, and you do your work, and you do good work, and at the end of the trip, you leave. This is how I think it's still being done for the most part in terms of surgical missions. And when you start doing that, when you do that enough, you realize that there's something missing from that model, and what is missing is what you've heard about today, the notion of building systems and building partnerships and making your relationships more horizontal rather than vertical. Is there another way? And this is Dan's slide that he gave me months ago. Sometimes just boiled down, and he's actually, I think, occupying the leadership position at UCLA in developing this sort of perspective and developing this sort of programming. In his case, in Mozambique, but this is going to be universally applicable to anywhere we go. But it's more about an exchange, not the advanced Americans flying in and giving these poor people what they need and then leaving, but building sustainable programs and building mutually beneficial relationships. I think the core of this is for us as visiting surgeons to have some degree of humility and to realize that we have as much to learn from our hosts as they have to gain from our presence there. And part of that is, a large part of that is having some cultural sensitivity and having a pretty keen sense of perspective. What do I mean by that? When we fly in, again with this parachute model, we're laser focused on the medicine, what we're there to achieve. I want to do as many cleft lip and palates as I can. David wants to do as many hernias as he can, etc. But what a lot of times we fail to realize is that the people who we're trying to serve, that's a very small part of their existence, that they're trying to deal with feeding their children. They're trying to deal with having 8 kids and a dad who has a hernia, who can't lift and who can't provide for the family. So I think that we have to take that into consideration when we attempt to help these families. And because each family has a story, there's a bunch of quotes on storytelling. And Khalil Gibran said, it has been said that next to hunger and thirst, our most basic human need is for storytelling. So it's not hunger and thirst and a cleft lip repair. It's hunger and thirst and what is this family story? Because the cleft lip is only part of it. So my goal has been to, as I've come to realize this, my goal has been to try and become more involved and engage with these patient stories. And this is an example of why it's become very important to me. This is a child who we operated on in Guatemala. We got this picture a week later. Her cleft lip repair fell apart 2 or 3 days after we left. So this is a tragedy and a travesty. But most importantly, the question is why this happened, because this is something that's described. It's very rare, and I've never seen this in 10 years. I've never seen this happen here in the States. So what's the story behind this? I don't. What I need to do is figure out why. And you guys know, and you guys, many of you probably don't, but when you go to the developing world, your patients have this smell. And I always thought it was just because of poor hygiene. And it turns out that in Guatemala in particular, the indigenous population, which is the population that we tend to serve, they all have open fires in their homes for cooking and for heat. And so this is actually an epidemic across the world. 3 billion people in the developing world get their heating and their material for cooking through open hot fires in the home. And it causes illness and premature death. The women and children who are in the home all day are the most affected. And we all know, and particularly in plastic surgery, we know that wound healing is very dependent on ideal conditions, and smoke inhalation is horrible for wound healing. So that's part of the story. So I asked myself the same question: how can I help that issue as it relates to my patients? Well, we partner with an NGO, and we went to Lake Atitlan region of Guatemala, which is a pretty idyllic setting. And if you take away some of the electrical wires, it almost looks like the Amalfi Coast. But if you look closer, it's actually a series of shanty towns on a hill and extreme poverty. And this is what a home looks like. These people live in the dark. There's no electricity. There's no plumbing. And when you hit the flash bulb, this is a family that lives, there's actually more members of this family that lives in this small constricted space. And you see all the walls are black from soot from the fire. And you see the flash bulb picks up the little gray fleck. So this is what this child here that mom is holding is breathing in from day one. And if that's my patient, that's what that child is going home to. So with a little bit of elbow grease and a little bit of time and money, you can radically change the lives of a family. This is prefabricated cinder blocks and ceramics, and in 15 minutes you can build this stove that will completely change how a family exists. And this is what you get. And I love this picture because the little girl's looking at her mom thinking, what the hell is going on here? What is this thing? And this mom immediately, in tears, she put her boiling corn on the stove, which she was going to use to make her tortillas that night. And she told us that night was going to be the first night that she would ever remember, and in her family's lives, when she was a child, that they would have food that didn't taste like ash. So does this make me a better surgeon? Does this make me a better cleft surgeon or plastic surgeon? Does it affect my surgical technique? It may affect my technique because maybe now I'm going to use stitches that last longer than the ones I usually would use, knowing that these environmental conditions that the patients are coming from are challenging. But more importantly, this is Bonnie Tao was actually here in the audience. She's who I spoke to. It made me value the importance of the patient's story. So I won't go overseas now without Bonnie. And she's an anthropologist, a medical anthropologist. So before surgery, she's talking to the local caregivers who are preparing the patients for surgery. While I'm operating on this family's child, she's talking to them about what their beliefs are about a guy who, scary looking guy like me coming and taking their child and doing something that they really don't appreciate, no matter how much I try to explain. Then after surgery, with this child in the recovery room, fresh out of his cleft lip repair, she's listening from the mom what her experience is about that. And so by engaging in the storytelling and respecting the culture that the patients are coming from, we take this situation, you can tell from their body language that this is sort of the defensive, somewhat suspicious posturing. We become part of this community. We're now all on the same page, and we're engaged in the same goal. So, again, I want to thank everyone for coming, and thank all of our leaders and mentors for providing us with the opportunity. And that's it. That's all I got.
Thank you very much. Thanks to all of the panelists. I'm wondering if I could invite the speakers to come up and sit in front. We'll save one chair for Catherine Gillard and bring her in by hologram. So, questions or comments that you might have from the audience. I would very personally like to thank all of the speakers because you demonstrated not only incredible skill, but also an incredible spirit and a spirit of sharing the wonderful things that we have here with people around the world. Questions, comments, please.
Well,
Dr.
I would
Busuttil.
also like to congratulate all. I've had the honor of being involved with most of you all in the development of the program over the last several years. I kind of check off what I'm most proud of that's happened in the department. I've got to say that this Global Health Initiative, what you are doing for so many others, don't have the opportunity, so you all get there. I think that's what we are as physicians. I don't care how great researchers we are, whatever we do, our focus and our goal is to people best and most humane way while we're really doing it.
As I listened to these magnificent presentations, I realized that when I started my surgical internship at Bellevue Hospital in New York City, and now the United States is becoming really a melting pot with people from all nations and countries coming here with their cultures and problems. I was told first day, if a Chinese patient comes in, they're here to die. They don't come to the hospital unless they're dying. And obviously with the Puerto Rican population and to LA with the Latin American population, I mean, I had to, even though I was in this country, I was experiencing these same cross-cultural shocks and adjustments, and had to learn how to deal with the population. So it has validity. It's not just a few enthusiastic people going around the world. I mean, everything they're learning is really immediately relevant to what we're seeing now in our emergency rooms and patient population.
And I think one of the important issues is that the disparities that we experience between a place like the United States and some of these other countries are also true, not only in the United States, but in our own county. So these are very relevant experiences indeed.
I'm curious, a lot of you sort of address this, I guess, indirectly in terms of missions. But I'm wondering what influence religion has, sort of both in the group that's going down and in the population that you're serving. A lot of times it seems like that bonds people together, and I'm wondering if you've had experiences with where maybe one side and the other side don't necessarily agree, or how you have people from the group coming down that may not all believe the same thing, and how that's sort of involved in more missions, I would think, in partnership, but probably both.
So there's the issue of both religious and perhaps non-religious people, but then the variety of religions that one will encounter in a particular place. Anyone care to comment? Gene, you?
It's a really complicated question. I think, for example, our organization, we only take applicants who have a Christian background. And part of it is that in any global health initiative, or even what we do here at UCLA, we don't think about it in cultural terms, but we want to promote a certain culture of care, a certain culture of education, a certain culture of how we do things. And so part of why ours is faith-based is that religious beliefs or your worldview has a very powerful effect on how you see the world, your patients, colleagues. And so with that, it's very complicated because we take care of patients who are Orthodox Christian, many Muslims, people with backgrounds. And so part of our belief system is that we must work together with people. In the U.S., a lot of times these religious conflicts are heightened by what's seen on the news, but for many of these countries, they've been living for millennia on the ground together. So I think to understand that, to work together, to kind of teach common core values that we have together, I think that's where you start, and then other things you have to sort out. And sometimes it's very, very messy.
Anyone else care to comment? How do your own personal religious beliefs or spiritual beliefs affect what you're doing?
For our organization, I mean, we're specifically non-denominational. And the thing is that I think your own personal religious beliefs motivates you into what you feel like doing and what you want to do in life. But the organization specifically is non-denominational because I think medicine has no religion, it's humanity. And so that's the nice thing about it. But many of the members in it are that clearly you have some spirituality because it motivates you to go do these things.
I think also, first the term surgical mission, I think, has its roots in some of the earlier faith-based groups that help these. But I think on the flip side, you have to. I agree with 100% with we are. We're humanitarians, or we are surgeons. You have to be aware of what patients you are trying to serve believe in. So, as Cal, when she's talking to patients, all the indigenous patients and peoples of Africa, they believe in a shamanistic type of, certainly in terms of their local religious authorities. And if you discount that experience, then you've lost your patient's faith. You've lost their confidence, because that is a fundamental part of their existence, the belief in that system, which doesn't necessarily jive with Western medicine. So I think that from my experience, the more aware and sensitive into those beliefs, and the more I can bridge this very foreign notion of surgery to what a shamanistic healer is offering, and the more successful my patient doctor interaction.
I think one of the interesting things I'd like Chi to comment on is what is it like functioning in a Christian-based hospital versus what it's like to practice in a private hospital versus a public hospital in these countries. So I work in a public hospital, which is poorly staffed, limited resources. At this moment in Mozambique, there really isn't much private hospital system. But in some countries, you can get just as good care in Lima as you can in the United States. So when we think about where we want to send our residents, while UCLA is a non-denominational institution, and we try to separate religion and care, there are certainly, in some cases, opportunities in Christian-based hospitals where the opportunities to be able to care for patients and train physicians may be better than in the public hospitals. And that's something that we're struggling with. So I don't know, Chi, if you can comment on that and inform us a little bit about the landscape in Ethiopia.
Yeah, I think, again, the worldview that you have and religion is a very big part of that. dictates some of the activities that go on. So, for example, from the worldview that I espouse, even the best doctor or surgeon, we only prolong life. We're not, if we think of life in an eternal scale, then we're only doing something very temporary. So there will be other there to address the spiritual needs from that kind of background. Now, the hospital that I'm at is in a unique position because they're supported by a mega church in Seoul, Korea, that has 100,000 members. They put down a lot of the capital to build the buildings and such, but they are, the staff is almost 100% Ethiopian, and they are, budgetary-wise, self-sustaining. So a lot of the supplies and other one of the better supplies and staff hospitals. Just like some of the government hospitals here in this country are often under various financial pressures and other constraints, government system there, even on the highest academic institution really struggles to have their ORs running. Autoclaves break down all the time. So in terms of, I think you need to find a hospital that can really function and do what you want to do together, whether it's private or.
We have a long-term collaboration with a faith-based missionary hospital in Malawi. We've been there for about 10 years. But they have developed a similar model. That is that there's a fee-for-service side of the operation, and then there's a clinic side of the operation. The fee-for-service side takes care of government officials, expats, UN, people in country, the CDC, and so on and so forth. Generates quite a bit of revenue to support the other side of the operation. That is one way of upgrading public service.
Our hospital uses.
Yeah, it's an interesting one. David, I wanted to ask you, the use of technology is very clever. As you say, Facebook is ubiquitous in around the world, as are cell phones, and internet access is becoming more acceptable in very many different places. The metrics that you used and the login technology and the technology to track patients and then the checking technology, do you see that as a way to expand to a lot of different surgical areas?
Yeah, absolutely. The reason why we want to tackle hernia is because it's clean and you can come in and out. You can define a problem and say what you can have metrics to say what have you done about it. Otherwise, if you're doing multiple different operations, it's hard to say. So here we could say we're doing one operation. We can have a model for training, but it really is for everything. It's really how we approach our own residencies now. That we want to say we want our residents to come out and be competent in each operation. So these are things that the same surgeons that I train for hernia call me at 3 a.m. and say I have this rectal cancer. What do I do about it? So we want to be able to set up a system where they learn about tracking outcomes, about how to do operations, about how to access resources, about how to access other surgeons, and then about how we can just be connected in terms of if I leave Google Glass for them, or if we sent out a GoPro to our other guys, and then you just put it on, we can watch them from the office. So it's really an amazing technology. It's actually done more overseas by using it because it's hard to implement these things here because of HIPAA, privacy laws. So over there we get the consent of the patients, but technology, this is other billion-dollar companies are building this technology for other reasons, and we're leveraging it for free.
Well, I want to thank. Oh, one more question.
Sorry, there is a perception of surgery surgical interventions as being expensive, and I just was curious as to what kind of, what have you been able to do to kind of reposition those perceptions in any way, saying, okay, this is so resource heavy, but and patient very specific, and so what are you doing to change that perception of it being too expensive, which is. I don't know who to address that to specifically, but
one of the problems is marketing this, and so surgeons have not been successful, I think, in getting the bulk of WHO and global funding for our activities, and I think that's changing. You've seen Katrine in developing Global Surgery Institute at UCSF, and more surgeons are successfully competing for grants and for resources, and some of that will require that we study the economics of surgical care. We've already got some data that Sean demonstrated showing that taking care of some of these conditions is just as cost effective as preventing against other medical diseases. Part of getting support is also the selling of the topic. So if you look at a lot of surgical missions, they show kids with cleft lips and pouts, and it's pretty easy to raise money for that. Rez is pretty lucky, but when I've got imperfect anus kids I want to take care of, it's hard to show pictures.
I would say, though, that my former mentor and current colleague, Dr. Heidi DeVos, is involved in one of the Lancet policy series on global surgery. So it is an issue that's really rising nationally and internationally. Dr. Washington.
Tom, just a comment. First, I enjoyed the discussions very much. Each of the presentations. Interesting, informative, stimulating, and inspiring. I turned to John and I said, I don't know if they rehearsed, but they're also articulate. And John doesn't miss a beat. He say, they're surgeons. But no, more seriously, I wish that we could bottle this morning when I put on my development cap, and I don't know if we recorded it. But this, to me, represented a special moment in terms of you telling the story of what's going on as whole surgery initiative. And it reminded me of, since you mentioned the Lancet, of what Richard Hart, I think he's Sir Richard Hart, editor of Lancet, wrote in an editorial in April after having visited UCLA for the launch of our new Center for World Health. He opened his editorial, 4-page commentary, by saying, I just saw the best of the U.S. On display while at UCLA participating in the launch of the new Center for World Health. I would take that statement and say this morning I feel like I've just seen the best of UCLA health sciences and what we currently offer, the promise that we hold for meaningfully changing the lives of people all around the world on display this morning. So I want to say thank you to all of the presenters and all involved organized. Truly a proud moment. For me, it's Dean, but I think for everyone in this room. These kinds of
Your conference is scheduled to end in 2 minutes.